had an enormous olfactory area as well. Okay. Olfactory groove meningiomas grow here, and they are quite common benign tumours that press upwards, and they take about 10, 20, 30 years to realise symptoms. But when a patient is becoming a bit dotty because the patient's actually tumour is growing and pressing on their frontal lobes, they've had anosmia for many, many years, but they've just put up with it because here in Britain we don't care about our sense of smell, whereas if you're French or Greek or whatever, that would be an absolute tragedy. It would be for me. I would not be able to smell Je reviens when my wife puts a little bit on, or Quelques Fleurs, or Montrachet, or something gorgeous like that. I mean, it would be the end of my life, the fact that I couldn't appreciate, because of course taste is mainly smell, isn't it? In a human sense, taste is smell. Sorry? No, I think we're okay. Here is what I was talking about, an olfactory groove meningioma. That's quite a small one, actually, but if it got huge, it would actually present by virtue not of raising to cranial pressure, because it grows so slowly, but rather pressing on frontal lobe structures and the patient starting to become a bit gaga, dementia. This is what I was talking about, fracture. And here is the classic sign for those of you who are in final year and are interested in anything to do with trauma. This is I call this the raccoon or panda sign, which is typical of a fracture in this area. So this lady might dribble CSF and she might have anosmia. Clinical correlation. Now let's come to something for you probably far more important. And this is the optic nerve, which I'm told by clever neuroanatomists isn't really a cranial nerve at all. It's actually an outpocketing of brain tissue. And this explains an unusual thing. The optic nerve has a dural sheath around it, and it's the only cranial nerve to have that dural sheath, which might, in a way, because it's got CSF around the nerve, partially explain the phenomenon called papilledema, when you get raised into cranial pressure. I have a picture of that in a moment. So let's look at the optic nerve pathways. The light is coming back here, and we get to, this should, I think, be called LGB, the lateral geniculate body area. I always remember L for light, L for lateral, if that's any help. So the lateral geniculate body is receiving light. And then fibers come in to the mesencephalon midbrain area, which is concerned with the light reflex. But we are also aware, of course, that it comes out to the actual visual cortex through the optic radiation. Now, for a neurosurgeon or a neurologist or a practicing clinician, I say, we can look at what might happen if we actually have a problem of the optic nerve, the optic chiasm, or the optic radiation, because, of course, we get different types of field loss. Obviously, if you cut the optic nerve, you're blind in that eye. If you shine light into that blind eye, there's not going to be either direct or a consensual reflex, because it can't get over. If you shine light into the right eye, on the other hand, the blind left eye, the pupil should still contract, because we're going to come to the third nerve in a moment. You've still got the possibility of a consensual reflex. Light crosses in two places as regards the light reflex. One is in the optic chiasm, and the other is in the centre, in the so-called pretectal area. I've got a slide to show you that. There's also crossing there in the midbrain, just near the third nerve nuclei, but just behind that called the Edinger-Westphal nuclei, which actually project parasympathetic into those oculomotor third nerve nuclei. So one of the commonest visual problems I see as a neurosurgeon with a tumour growing here in the temporal lobe, because this is temporal lobe with the optic radiation, is bitemporal hemianopia. So a left temporal tumour would cause a right homonymous hemianopia, like that. You understand that, don't you? And I think that's very important. Whereas, what type of visual loss would we get with a chiasmatic lesion? Can you shout, somebody? That's right, bitemporal hemianopia. So you lose because of course there, I haven't explained that properly. When you get the light crossing over in the lens, the nasal retina fibers are the ones that are going to cross, the nasal retinal fibers are crossing mainly in the chiasm, and it's the nasal retina fibers, those grey ones, that are subserving the temporal, the outer fields, the temporal fields of vision. Do you understand? Right. So a lot of people find that a little bit, I'm all mixed up sort of thing. Right. Okay. Brainstem connections. So here we've got the what we were saying before. What is that? The answer is the lateral genicular body. I've given the game away. Fiber tracts come in. This is brainstem here. Crossover, as I said, behind the Edinger-Westphal nuclei, which I look upon as parasympathetic, simply outflowing to ocular motor. And therefore, we can't consider 2 without 3, really, and we get the contraction of the pupil. We'll come more to 3 in a moment. Okay. And we also have a topographical relationship here as well, which I don't think is terribly important for you to know about. What is also interesting, and maybe another slide in a moment, is that some problems of the occipital region lead to blindness but spare the very important macular area of the retina. Why might that be? So if you get a lesion, particularly an occipital infarct from the blood vessel to the posterior cerebral artery being blocked off, or a branch of it, you are blind for your fields, except you still are preserving the macular region, which is, of course, a very concentrated area for fine discriminatory print. So you might still be able to read a book, but you're actually otherwise peripherally blind. And the reason for that, by the way, is that the macular area on this, more or less where that arrow is supplied by a different artery called a branch of the middle cerebral artery. So an occipital infarct may spare macula by virtue of a different blood supply to that tiny area which is macula, just on the inside of the visual cortex there. There's the lateral geniculate body there. It says LGN. I suppose that's N for nucleus, but I would call it LGB, actually. Again, a different way of saying what we have. And here is a picture which I could have got from one of my own slides, but I cribbed it from the internet, and that is a tumour, a cellar mass, pituitary lying in the sella turcica, hence the word cellar there, and that's a tumour that classically would grow and cause bitemporal hemianopia, comme ça, bitemporal hemianopia, because that's coming from there. We do a lot of neurosurgery on pituitary tumours, and do you know how we get at them, by the way, in terms of anatomy? We get them up the nose, transphenoidally. Very interesting to recall that that is the way the Egyptian pharaohs took the brain out. Okay, next slide, please. He said to himself. Oh, here we are. And that is one of the aspects of optic nerve function optic nerve examination. This is papilledema, okay? And one of the things that I go on and on and on about with my final year students, I say, how many of you have got an ophthalmoscope? And there's a look of horror because ophthalmoscopes cost a lot of money, quote unquote. Then I say, how many of you have got an iPhone? Got the hands in. And he said, so certainly an ophthalmoscope costs less than an iPhone, for sure. And I think that if I can still advertise this little bit, but in final year, think when you qualify, as you all will here, I'm sure, about buying an ophthalmoscope. It's the most useful instrument for F1 and F2. You will say, well, I can get them on the ward. People steal them, they don't work. Have your own ophthalmoscope, get it engraved with your name on it and make sure you've got one. About 150 to 200 pounds. I've still got the one I have in final year, and I use it for, I could go on and on bore the hell out of what I use it for. But, you know, hypertension, glaucoma, papilledema, diabetic retinopathy, looking at the cornea for foreign bodies in casualty with a bit of fluorescein, on and on and on. So we've got the light reflex to remember. And of course, when we actually test 2, there's a few things to do.